Welcome everybody this morning. We'll just let everyone join, and hopefully Amy's going to share the slides shortly. There we go. If you can just put those in the presentation mode, Amy. Right, welcome everybody to this webinar this morning on insights. Really pleased that so many of you are able to join us. I'm Hazel Cheeseman. I'm Deputy Chief Executive at ASH, and I'm going to be chairing the discussion, but I'm going to say very little. Really soon I will be handing over to Sonya, who has conducted this insights work for ASH, commissioned at the end of last year with funding from the Department of Health and Social Care. And after we've heard from Sonya, then we're going to get some sort of expert responses from people who really probably need no introduction. Louise Ross from the NCSCT, and Andy Lloyd, who's long been the communications lead for Fresh in the Northeast. And then we're going to have a really interesting Q&A, I hope. The chat is open. Really, the success of today is going to be how much contribution we get from you and your thoughts and questions about the stuff that we discuss, and really hoping that we can have a really vibrant discussion. I'm just going to say a few words if we move on to the next slide. Oh no, housekeeping, that's really important. So just so everybody knows, the meeting is being recorded, and the recording will be circulated to all attendees. And it will be up on the web page, and we will also make available the slides as well. Panelists should keep themselves muted and the videos turned off unless they're presenting. And yeah, as I said, please put your thoughts and contributions into the chat and the Q&A. We will try to make sure that we cover as much content in the chat during the Q&A as we can. And if there's anything that we don't get to cover that's important to pick up, we will do afterwards. Amy, if you just want to move to the next slide. We still got people joining the meeting as well. Looks like we haven't let everybody in. That would be a shame. Okay. So just to remind you all, we have marketed these events as being this is the first of 4 events that we're going to be running around this insights work. And Sonya will say a bit more about how we've conducted this insights and when she does her intro slide. So the session this morning is going to be a really good intro really to all 4 of the sessions, but particularly to the one that we're going to do on Tuesday, which will focus in a lot more detail on disadvantaged groups. All of the insights work was done deliberately with disadvantaged populations. So much of the stuff that we're going to talk today is completely relevant to disadvantaged populations. But we're going to look at it more from the perspective of the impact of the pandemic, cost of living, and what the implications are for our kind of mainstream services and communications approaches. And then on Tuesday, we're going to take more of a deeper dive into those groups and think a bit more about the particular relevant insights for those populations. I think we've got the wrong description under Tuesdays. That's talking about the pregnant smokers. We're joined by Frances Thirlway, academic with some particular interest in working with disadvantaged populations on Tuesday, and a speaker from Clarion Housing as well, a social housing provider. Okay, just move on to the next slide, Amy, and then I'll hand over to Sonya. So as I was saying, the purpose of this is to really look at the impact of the pandemic and cost of living and focus on our services and communications approaches. We want to keep the conversation open. Please use the chat. And then, as I said, I think I've said all of this already. I preempted this slide. So if we stop sharing my slides at the moment, I'm going to see if Yelena and Amy can maybe figure out how we can let people into the lobby without it dinging. That would be brilliant, but I don't know how to do that myself. And I will hand over to Sonya to give you a bit more detail about the insights work that we did.
Thank you very much. Let me see if I can pull this up.
that's great. I can see that, Sonya.
Fabulous. So thank you very much, Hazel, for the introduction, and hello to the hundreds of people who seem to be beeping themselves into the session. So what I'm about to present draws from a wider bit of research that, as Hazel said, was commissioned just before Christmas, but carried out early this year. And it was to do qualitative exploratory work with, as Hazel said, disadvantaged communities. And on the right is the list of profiles that we recruited to. In total, we did 18 focus groups, 41 depth interviews, and all of the people that we spoke to, apart from the healthcare professionals, were routine and manual workers or people who'd never worked at all. And on top of that, we spoke to people in coastal communities, people living in social housing, living below the poverty line, etc., as you can see on the right-hand side. In this session, we have taken selectively from the wider research to look at these groups' experiences of quitting, relapsing and accessing support, particularly through the lens of the Covid-19 pandemic and the emerging cost of living crisis. And I suppose one of the things to say is, because we did this work at the beginning of the year, that cost of living crisis was emerging. It was certainly starting to make itself self-evident, but perhaps wasn't as dramatic perhaps as we would see it now. So just to put some context together for you, for the people that we spoke to, and as I've said, we talked to people who, using the ONS socioeconomic classification, fell into routine and manual workers and those who've never worked. But although we are pulling these people together, I suppose, as a group in this work here, that group contains a very wide range of people with a wide range of circumstances. And of course, there are some factors that are common across all smokers, but there is a very wide range of situations present in this group, ranging, for example, from a single mother of 6 that we spoke to who couldn't work because she couldn't afford childcare, and was struggling to feed the children using food banks, etc., through to people who perhaps were a couple both working in fairly secure routine and manual jobs, but had job security, had secure incomes. So quite a range of people. But very much something that came out is that a lot of this group lead very challenging lives, very stressful lives, and are quite chaotic. There's a lot of financial vulnerability, as you would expect, and people are living very much on a firefighting day-to-day basis, crisis to crisis sometimes, and not a lot of longer term thinking or planning amongst many. And clearly that's an issue when it comes to things like the cost of living crisis, but we'll come on to that a bit later. And there's a couple of quotes from 2 of the participants of the research. The single mum of 6 that I spoke to, so she was taking help from the council, relying on food banks, etc. And then a BAME smoker there who's saying, yeah, we're starting to feel it, but actually we've got 2 incomes. So whilst we're feeding it and we're cutting our cloth accordingly, it's not dramatic. So quite a disparate range of people in the group. When we look at the pandemic, one of the things that was very evident in the work that we did was that the impacts were quite widespread and quite dramatic amongst this group, typically financial and linked to mental health and well-being. And those 2 things are, as you can imagine, very interconnected. How impacted people were financially depended on what their working status was, whether they were furloughed. For some people, furlough was okay, 80% of the salary was okay. For some people, actually losing that 20% was quite critical. Some people, suffered even more significantly. And the younger smokers that we talked to, we spoke to some NEETs, not in education, employment or training, having fewer worries because typically they were living at home, so they were less concerned about the pandemic and very much so the cost of living crisis. So some people lost income, and then there was sort of a double whammy, because a lot of people said, you know, having all the family at home, having the kids at home, having to feed them lunch and dinner every day, you know, no school meals, those sorts of things, created more financial pressure for many. And some who increased their smoking because they were at home during the pandemic also noticed the financial impact of that. I think not everybody that we spoke to suffered from increased mental health issues because of the pandemic, but there were a lot for whom it was a significant impact. It really can't be underestimated. And for some people it persists, although some people feel that as life has returned to normal, they've been able to, you know, get on top of those issues. For some people, on the other hand, lockdown brought benefits, that sort of time to increase your fitness, go for those daily walks that we all were told we should possibly be having. Having the family all together, some people really appreciated that. The enforced slowdown of life, some people took stock of how busy they'd been and really relished that slower pace of life. And for some people, it's been more difficult getting back into, in inverted commas, normal life. Quite a few of the people that we spoke to who suffered mental health issues felt that it wasn't right to go to the GP, that GPs are overloaded with mental health sufferers and everything else. You'd only get redirected, you might not get the support that you were looking for, and that there was a few that commented that, well, anyway, you can go and see a GP during the pandemic. And quite a number sort of feel that, well, you know, this is that I've just got to look after myself in this instance. You know, it's all self-care. The cost of living crisis, as I said, we were at the sort of emerging stages of the cost of living crisis back at the beginning of the year, and some were very much aware that although they could see you know, prices rising, particularly petrol at the time, but were aware that there was pain to come. Fuel was what they spoke about most. I think since then we've seen a lot of sort of grocery price increases, but they perhaps weren't happening at that point. Some talk of saving and budgeting, but there were plenty who were just saying, well, I just don't know how I'm going to cope. I'm just going to put my head in the sand a little bit. You know, I'll just worry about it, but I'm not really planning a solution to it. Heating costs seen as less controllable than car fuel and food costs. But there was evidence that some people were already, given that it was sort of spring when we were doing this, winter into spring, were already not using the heating as much as possible. And a quote there from someone saying, you know, it's a choice between eating and heating myself. A lot don't have a strategy for how they're going to cope. A lot are in denial. It seemed to be more likely to be men that were sort of putting their heads in the sand about it. And all of this has another impact on mental health. We spoke to a few people who talked about having been prescribed medication to help them deal with the additional anxiety and stress caused by the cost of living crisis. And here's a quote from a lady who was living in the south. She was living below the poverty line and really struggling to heat the house. She's on universal credit. What impacts did the pandemic and the cost of living crisis have on smoking behaviour? Well, the pandemic seemed to have a mixed impact. Some people increased their smoking. A lot of people talking about, well, there was nothing to do. It was really boring. It was increased stress made me smoke more. And a lot of people said, and I'm continuing to smoke at those levels. I started smoking more and I've not reduced that again. People talked about having been quit before the pandemic arrived, and then the stress and the anxiety and the situations causing them to lapse from quitting. And all of that brings increased financial pressures, which in turn increases stress, which in turn increases smoking in some cases. We talked just a minute ago about some people really loving having the kids at home. For some people it was a big pressure, and you know, smoking gave them an opportunity just to step out of that hectic sort of hothouse of everybody being in the house, you know, stand in the garden, have some me time, having a cigarette. Some people, on the other hand, smoked less, either to cut costs if they felt they could do that, or because their situations. So with smokers, some people smoke at home but not at work. Some people smoke at work but not at home, especially if they've got children. So for people who smoked at home and who didn't smoke at home, actually being at home during the pandemic helped them cut down a little. And there's a quote there, someone saying he used to be quite a heavy smoker until COVID and felt they couldn't afford it, so cut back. The cost of living crisis was, as I said, starting to hit. Mixed views on how they were going to cope with the smoking as things got worse cost-wise. Some people talking about already making some changes, and the primary change that we saw was people starting to roll their own and using tobacco rather than cigarettes. Some were quitting, some were trying to quit, trying to cut down, and some have done both. Both switched and tried to cut down. Rolling tobacco, a very obvious way for people to save money, because not only is it cheaper, but because it can be eked out, so you can have smaller cigarettes, you can ration how much you put into your homemade cigarettes. But quite a few people sort of saying, well, you know, no matter how bad it gets, I will find money for my cigarettes because I know that's the way it is. Some worry about having to cut down. And for many, the extra stress and the anxiety just makes it worse for them, makes them turn to cigarettes even more. And we saw evidence of more people buying cheaper cigarettes, especially cheaper tobacco, which, although some didn't clearly state it was so, is likely to be illicit. So some move to the black market there. And then a mental health sufferer there sort of saying, you know, it's all very stressful, I'm worried about the increase in prices. And then I think, oh, you know, I'll have a fag, that makes me feel better. Sort of goes hand in hand, stress and a fag. And that is a dominant theme for a lot of people. In terms of barriers to quitting, people state mental health issues, whether they're, whether they're quite severe mental health issues, or whether they would perceive them as milder but day-to-day financial stresses, but barriers to quitting dominated by mental health concerns. People worry that if they quit, they might fall into depression, and the pandemic and the cost of living crisis enhanced all of that mental health and smoking link. There's a strong sense from people with mental health issues that, you know, my life is hard enough, and to give up smoking will be a double whammy of sorts. So not only will it take away one of life's pleasures, it'll take away, whilst giving me extra stress because I can't smoke, it will take away my method of coping with stress. So it's a double negative for those people. And we talked with our respondents about the fact that stopping smoking might help them manage their stresses and anxiety and mental health issues a bit better, but people find that almost impossible to believe. Younger smokers, in terms of thinking about quitting, don't feel it's a pressing priority. They're very naive. Oh, I'll quit when I'm 30, I'll quit when I have a baby, I'll quit when I move in with my girlfriend, those sorts of things. They don't actually recognise that by the time they get to that stage, you know, the addiction will be such that it will be a hard task. Others talk about the fact that socially smokers are seen as pariahs, as social outcasts, and it makes them feel a bit resentful and rebellious. And my doctor always tells me I need to quit, and you know what, I'm just going to do what I want to do. There are other specific fears about the impacts of quitting. You know, I don't want to put on weight. And certainly I remember speaking to one woman who'd woken up and looked at herself and said, I started smoking again because I'd rather be a smoker than be fat. You know, people worry about drinking more, and others fear failure. They don't want to put themselves in a situation that sets them up to fail. People talk about the worry, I don't want to spend the rest of my life wanting to do something that I can't do and having that craving all of the time. Some people are defeatist. particularly older and more entrenched smokers more likely to say, well, it's too late for me, it's impossible, it's just too difficult. And a lot of people in this group of people that we spoke to justify not quitting yet and saying, you know, you can only quit when you're ready. There's no point trying until you're ready. Only I can quit for myself. I've got to be ready. But they don't feel ready, and they also don't have any sort of strategy for becoming ready. So you have to be in the moment, but how you get to that moment is a bit of an unknown amongst some of these smokers. And this guy, I'm just set on doing what I did before, setting that date in my head and sticking to that. And then once I get to that point, that's when I'll stop. It's just with everything, the build-up of stuff and stressing out all the time, I can't quite get that set in my head. And so that's a very common theme that we hear amongst smokers, which puts off the quit attempt. In terms of the pandemic, it did have differing effects on smokers in terms of quitting. As we said, some smoked more. But for some, lockdown and the anticipation and experience of having COVID did trigger a quit attempt. So we spoke to quite a few people who'd talked about, well, I was going for these walks every day, I realised how breathless I was, or I had the chance to start working out more, I did some cycling, and I felt, why would I do that and not try and give up smoking at the same time? So it did provoke quit attempts there. Some people quit or tried to quit because of the worry about having COVID and the message that was getting through that for smokers COVID was worse. And actually the reality of suffering from a COVID infection, people were saying, you know, I quit because I got COVID and I could barely breathe and certainly wasn't going to have a cigarette then. Some people talked about comms campaigns and general communications of increased risks for smokers from COVID. So those things did have an impact in terms of triggering some quit attempts. In terms of relapsing, the hurdles and the pitfalls that smokers fear, all the things I just mentioned, are in fact the reasons that they fail to quit or they relapse. So stress, and that can be day-to-day stress, it could be a major event, will make them turn to the cigarettes. Boredom, mood swings because of the withdrawal from the nicotine, feeling ill. Social situations with alcohol, they're an absolute minefield. People associate smoking with drinking, and actually having a drink makes it quite difficult not to have a cigarette. Weight gain, we spoke about that, and just giving in temptation. And some people, in fact, they're disappointed, they're frustrated, and a lot of the time they lose hope immediately after failing a quit attempt or relapsing from a quit attempt, think they'll never be able to quit. A lot of people say, well, you know, it was a miserable experience, this quit attempt, and actually I'm much happier when I'm smoking. And you know, that especially immediately after a relapse, people feel that they may not want to try again. So that's something that's quite interesting there. Talking to smokers about support services, most of them don't think about looking for help. Very few had sought support from any services. Some people reject it out of hand, talking about not being the sort of people who do that. For some of those people, it's about not wanting to ask for help. Others feel they don't want to be reminded every day that they can't smoke. They just want to forget about it and try and not smoke rather than have to talk to someone about not smoking. Some people feel uncomfortable about talking or engaging with a stranger. Others, and probably most of the people we spoke to, don't necessarily reject it, but they're not interested. They don't feel it's something that's relevant to them. There is discussion very much that services are no longer as accessible or as affordable as they were in the past. It used to be that you could go to your chemist and get NRT, but people perceive that that's not possible anymore. And people do have mixed experiences and stories regarding NRT, both positive and negative. Again, it comes back to this, it's down to me personally to quit. it's about willpower, it's about determination, and that if you haven't got those, then no support in the world will make the difference. And it's about being ready and relying on yourself to do it. And many said that, you know, they would take that approach first and see support as a possible plan B when pushed for it. And this quote at the bottom, no one else can stop smoking for me, and that's very much something that people think. In terms of what people understand and know about the support services that are available, if you ask people, they talk almost universally about their GP as a potential port of call. But some people do feel resistant to the GP, feel that sometimes they feel condescended to, nagged by the GP. You know, I think one guy said to me, you know, you could go with an ingrown toenail and they'll tell you it's because you smoke. So that's the sort of feeling that people kind of get a bit upset about, I think. Again, some question whether it's a good use of precious GP time to be dealing with smokers. People do talk about the local pharmacist, and perhaps pharmacies don't have the baggage, sometimes the negative baggage that GPs do have. They're both associated with giving out NRT, either paid for or free, and that they are seen as credible and reliable sources of advice and information. When pressed, people say, oh yes, I remember seeing a quit smoking poster or a stop smoking programme either in the chemist or the GPs or the supermarket. They can remember seeing something somewhere, but it's not something that's really caught their attention, even though they can remember seeing it, not something that's caused them to think. Some of our younger people remember seeing stuff at college that was encouraging them to get support for quitting. Not a lot of talk about the NHS and all of this, and very much a lack of knowledge and understanding about what is on offer. Some people talk about sitting in a group in a sort of Alcoholics Anonymous type setting. Some people talk about NRT, free vapes, counselling groups, but nobody really understands what support would be there available for them. In terms of what they would like, some were open to the idea that support would help. Some, when we sort of said, well, what about the statistic that you're 3 times more likely to succeed with support? They're interested by that, they're encouraged by that. It's not something they thought about. So not only do they not understand what is available to them, they actually don't have a reason for thinking that that would be a good idea to seek support. And so I think giving them these statistics and giving them, so this is the benefit, you're more likely to quit, is a positive thing. A lot of people we spoke to expressed a preference for remote support. They didn't necessarily want to go in. Again, though, we were much closer to the pandemic then than we are now, so maybe that was part of that. But it does feel more anonymous and possibly less judgmental to be more remote. There was a lot of people that we spoke to about the different types of support that were available, were interested in an app. They liked the idea of a cost savings calculator and tracking progress. And then because we were running these focus groups online, a lot of people were saying, well, actually, I wouldn't mind something like this. And, you know, people were talking to each other about, I had one group particularly who were all just about to turn 60. And one woman said, oh, yeah, I'm going to try and give up for my 60th birthday. And one guy said, oh, so am I. And, you know, it would be good to do that together. They didn't know each other from Adam, but that peer support and people are much more at ease online now. So that was something that came out quite strongly as a preference. People had mixed opinions on nicotine replacement therapies. A lot of people have heard about disappointing experience or worrying experiences. Some people have actually had those experiences themselves, feeling unwell, talk about hallucinations, things like that. And people are very much swayed by anecdotal reports in both cases. So some people say, oh, my friend did it, so I went and tried it. Or some people said, oh, my friend had this awful experience, so I would never do it. Comments on the expense of it when it's not provided free of charge. And some people saying, well, you know, it's more expensive than smoking. So if I'm quitting to save money, this isn't going to help. We talked to people living in social housing accommodation about whether services provided through the housing provider would be of interest, and it really it was greeted with suspicion more than anything at that point. So just to summarise all of those things, I've rushed through it. But my main points, I think, are that the financial and mental health impacts of the pandemic are very evident. They're still present, and the cost of living crisis is making that worse, especially from a mental health perspective for people. Smoking behaviours have been affected in varying ways and to different degrees. The pandemic did trigger quit attempts, but also caused relapse and increased smoking. Barriers to quitting dominated by mental health concerns, and mental health concerns are used to justify not quitting and as reasons for smoking. There is a perception that there's no point in trying to quit unless you're ready, but people don't know how to become ready for that moment. Causes of lapsing reflect the challenges of sustaining the quit. So people worry about being able to quit for these reasons and actually relapse for the very same reasons. But some people do just, relapse to escape the difficulty of the quit attempt. The disappointment of relapsing, the recency of the difficult quit attempt sometimes can discourage smokers from making further attempts. They can be discouraged from wanting to try and quit again. It's not top of mind to look for support. They don't understand the offer. They're not particularly interested, and some reject it. Some see it as a potential plan B. And GPs and pharmacists, top of mind as credible sources, although there's some barriers to GPs. And remote support and the app provoked interest, but very much not one solution suits all. So I shall stop sharing my slides there.
Tour de force, Sonya, thank you so much. And I think this, as I was saying at the beginning, I think this, and for those of you that have joined subsequently, I think this also gives us a really good intro to the event that we're going to have on Tuesday as well. We're going to focus in a bit more detail about the experiences of disadvantaged and particular populations. I'm going to ask Louise Ross to turn her camera on and unmute herself, and hello. Louise is going to offer a bit of a response from a service point of view, and I've certainly been noting down some of my own thoughts, and thank you to those that have added comments in the chat. Please keep doing that, and we'll get to those shortly. Louise, over to you.
Thank you very much, Hazel, and thank you, Sonya. That was absolutely fascinating. I've worked in stop smoking services since 2004, and a lot of what you've said resonated with me, but I suppose I'm struck by my own frustration with the fact that the wrong messages are still getting out to people who need and want to stop smoking, and simply don't know where to turn. And the image that struck me was somebody who needs to change the wheel on their car. If they wanted to do that, they probably wouldn't just kind of like sit there and look at the car and wonder what to do. They would ask for advice. They'd go to an expert. They'd look at a YouTube video. They would get some help. And I think stopping smoking is very much like that. That there is so much in the way of pathways, guidance, advice, expert support. And I pray that people will get more on board with actually getting hold of some of that. But I'll go through some of the points that struck me when I looked at your slides before today. And one was the very challenging lives of many people who smoke. They're juggling childcare, work, debt, and their own and family members' poor physical and mental health. So that issue of me time is so important, and we have to think about how to address that need for me time, and I'll come back to that in a bit. The lack of confidence in being able to stop smoking, accompanied by less than 100% commitment or interest, is very interesting. And again, I'll come back to that later in terms of what we can do to move people from being unconfident to being more sure that they actually, they could do it this time. That felt shame in asking for help, and you brought that out so clearly, Sonya. The idea that this isn't for people like me, or I must struggle and do it on my own. And part of that is the mystique around the stop smoking services. People don't know what will happen. They think they will get told off. They're still being told that they'll have to join a group. And this deters so many people. They don't want to be part of an Alcoholics Anonymous-like group, as you very clearly observe. Most services do one-to-one treatment now. So, if we've got frontline staff listening to this, you know, particularly in health, in social care, housing and so on, please make people aware that they do not have to join a group. They will get one-to-one care by somebody who will not tell them off, you know, will listen to them, but will share their experience in the best way of helping people stop smoking. And they're just people like all of us. You know, they're not, you know, there's no white coats. They're just regular people who actually care about people's outcomes. Yeah, and advisors having that how-to, they can help the client apply that to their own circumstances. So they're not going to say, you've got to do it like this. They're going to, you know, help people apply those guidelines to their own lives. The other thing that comes up is the big fear of nicotine, and again, you referred to this, you know, this idea that, you know, people will, if they use nicotine replacement therapy or a vape, that they're going to be addicted to something else. And I think one of the very, very clear messages that we can helpfully give to people who are thinking about stopping smoking is that nicotine without the smoke is like an anaesthetic for stopping smoking. It takes away the pain. And instead of climbing the walls with frustration and withdrawal and the rage that people fear if they try and do it without any support, nicotine can ease that pathway and make it much more likely that folks can adjust their lifestyle while they use clean nicotine to kill the pain of stopping smoking. You've come on, Hazel. I guess you want me to hurry up now, don't you? I think I'd encourage people to do the VBA training, because you don't ask people if they want to stop smoking. It's really clear that asking people if they want to stop smoking will get the wrong answer. Look at the VBA training on the NCSCT website and you'll get a better idea of the right questions to ask. Be open to vaping, because this might be the first time that someone has shown an interest in quitting. Don't close that down. And vaping can be a pleasurable alternative to smoking, replacing that pleasure that Sonya talked about, you know, that people were frightened of missing. Digital may well be easier to engage with, less personal, always in your pocket. And finally, Stoptober is just around the corner. Do everything you can to encourage people to give it a go this year, and use some of the insights that you've got from this webinar and the ones to come. Thank you, Hazel.
Thanks, Louise. That was really, really helpful. And I can see that it's in sort of encouraging people to have further reflections as well in the chat. And I think, you know, well, we're going to continue the conversation now with Andy about those communication messages, how we might interpret some of those insights into our communication campaigns. Oh, I'm so relieved, Andy, that I can see you. We've had some problems getting Andy to join this morning. Hopefully you can share your slides. And Andy, you might need to canter through them quite rapidly, because we're a bit behind time.
Do you want me to take over now? Yeah. As you say, Hazel. I mean, I think sort of this just reflects how smoker insight around smokers. It's not it can't be done in an hour. It can't be done probably even in a day or a week. It's a lifetime of insight. So I'm not going to even try and cover that kind of anything in the same level of depth, but I think it's just important to say kind of just understanding where smokers are, what works, doesn't work, has really underpinned Fresh's work since 2008, since we were set up. And we've actually been working with Bluegrass for the best part of a decade on numerous campaigns. So every time we run one, it's an opportunity to go out and talk to smokers, evaluate afterwards, and everyone brings its learning. So Hazel's just asked me to kind of whiz through applying it to campaigns and try and give a few tips. So I'm just going to try and sort of summarise a bit of the evidence base that has shaped campaigns, how this latest insight has shaped our Don't Wait campaign, a bit about PR and social if I have time, also pose a few challenges. This is really important because I think it's a reinforcement that campaigns, the academic evidence base around the world shows campaigns really important aspects of tobacco control programs. They help reduce not just adult but youth smoking as well. Even in the digital age, TV is still the most effective medium to reach and influence large numbers of smokers. It's also seen as much more believable, interestingly, because people obviously have a cynicism around what they see on Facebook. Digital, it's really important, increasingly important, it adds value, but it's not a replacement to those mass broadcasting channels. Not all campaigns are equal. Reach, length, message type all influence effectiveness. And there is particularly strong evidence for campaigns that highlight negative consequences of smoking, and real testimonials like Terry there from the Tips and Former Smokers campaign from America. Although really importantly, positive messages also can prompt help seeking. A bit more about that later, but the two work really well side by side. Campaigns increasing evidence shows are linked to higher quit success rates as well, and might help prevent relapse. Smokers who've just quit, seeing that campaign, that message, and just reinforcing the reasons. But a huge concern around, as highlighted in the Colne review, the fall in national spend by 90%. From about 25 million to 2.2 million. So very much a need to reinvigorate quitting, keep it top of mind, and make quit attempts more successful. There's obviously a lot of behavioural change theory, psychological insight underpins campaigns. I really like this quote though from Robert West, that they do something really simple as well. They're a trigger, like the fatty cigarette advert from the British Heart Foundation. Smokers still talk about that to this day, even though it's a decade old. Pat warnings. We know if you smoke, it's you don't want to think about the worst. You're surrounded by other people who smoke. You don't want to think about it, so it's easy to put them out of mind. But campaigns, communications, are a reminder, they're a trigger, and they work alongside, like the cues for people to smoke, as mentioned, like alcohol, like other people smoking around them, like stress. They work alongside those triggers in people's own lives, whether it's a cough, a cold, something more serious, cost of living, being there for family, important health interventions from a doctor. They all work alongside each other. They're like stones in shoes and reminders, and just bring it back up there to top of mind. So what do we know? This is some of our potted insight from running campaigns over the last decade. Sonya has been part of some of this insight as well. So, we hear that smokers know all the risks already. Well, they do. They know it's bad for them, but they don't realise the scale. So this is where sort of facts, information comes in. So we found, for instance, 9 out of 10 North East smokers underestimated the 1 in 2 risk. Around about half of them thought that risk was somewhere between 1 in 10 and 1 in 20. Graphic harms work. A picture tells 1,000 words. Impact on family and children could really give pause for thought and bypass when people are dismissing the personal health risks. Real stories like Michelle, who backed our Don't Be the One campaign. Doctors, they add impact, believability. We know age, as Sonya's outlined, can bring attitude, so a window of safety for younger smokers who think they'll have quit by the time it's a problem. Older smokers, that pessimist, that fatalism, that it's not worth quitting, any damage is done. And that combined with, as Sonya spelled out, the low confidence in quitting, previous failed quit attempts, people beat themselves up about it, and that stops them trying again. So we found increasingly that some of those messages around you have to keep on trying, and how the body recovers really resonates and sparks interest. We know costs are a major factor, especially for smokers who smoke sticks, but I think given the cost of living increasing, we need to think about how we talk about that, not as a solution in itself, quitting smoking, because we know smoking is not going to solve quitting smoking is not going to solve everybody's problems financially, but it will help a lot. Quitting for stress, a really important message right now, but at the moment it doesn't feel real or believable. So moving on to Don't Wait, some of you might have seen our campaign. It's what we've been running really for the last 2 years, and it was a face-to-face stop smoking intervention with Dr. Ruth Sharrock, a respiratory consultant, at a time when people weren't getting those face-to-face appointments during COVID. It's got the credibility, the impact of a doctor who kind of sees patients with those smoking-related diseases. Began life as Quit for COVID. It was the first TV ad worldwide to communicate those risks at a time when smokers were taking steps to mitigate the risks. And it's evolved since then into more traditional kind of quit smoking territory, trying to reach smokers at different stages. So we've got a harm route as a TV ad and an ad that we run on radio and on video on demand, which is about breaking bad news. It's about being there in a clinic, seeing what a diagnosis is like. Emotional, graphic. We have a lung cancer visual in there. But we've also got a hope execution as well, which is never being too late. And Ruth talking about how the body recovers, really trying to challenge that fatalism that the damage is done. We've had to reshuffle our latest phase, given sad events last week. So we launch again. We had to pause it. We're launching again next Wednesday. That will be with TV, with fantastic NHS support for that. The NHS really getting behind campaigns and seeing the importance of those. Radio, video on demand and online. And Hazel, do you think we've got time to play the Never Too Late one, or do you want me to just move on?
No, but we'll send it round so people can watch it.
Great. So I mean, just to sort of quickly outline the positive one, people really liked that. It was a different way to think about smoking. It gave them sort of new reasons. The harm one, we added retrospectively the lung cancer visual, actually, because actually smokers were telling us, you know, it puts you there, but it's not shocking enough. You know, that was actually smokers themselves saying that they needed that strong visual to really sort of to grab their attention. I'm not going to go through this in any detail, but needless to say, the campaign's been received very, very positively. We've seen a record number of actions taken, and it's been why we've continued to run it over the last 2 years. So high recall of TV, strong levels of people seeing it believable, easy to understand, health literacy aimed at somebody like them, not judgmental, an important message, and most importantly, wanting to making them more likely to cut down or quit. So 8 out of 10 smokers did something as a result. This has been a record in terms of actions taken for us. Now, of course, many of those will relapse, and not all, you know, some of those are people cutting down, but it's moving people in the right direction. And I think really importantly, you can see that, you know, people are having conversations. Over a third asked to quit by somebody else. So it's creating those talking points among families and communities as well. I am going to whiz now. It's not just about ads. We do PR right and social right throughout the year in companies' campaigns. You can do it on smaller budgets, deeper level of engagement when you've got case studies there, like Maggie during our Quit Smoking campaign. Lots of real stories. There's loads of calendar hooks, as you know, from Stoptober to World No Tobacco Day. We teamed up with Surfers Against Sewage for World No Tobacco Day this year to highlight tobacco and cigarette butts on the marine environment. But it's also thinking around as stop smoking services as well. If you've got direct links with smokers, you know, what direct comms do you have with smokers? Texts, emails, reminders, lots of follow-ups, newsletters. How are you applying some of this insight into those reminders to smokers that, you know, they're always welcome back, and next time it will be different with support. Digital and social, really, really important, as I said, although TV's the gold standard, this is increasingly important. Most of the awareness for campaigns is from broadcast, but most direct responses from digital. Some brilliant platforms out there like Canva and Catwing now that make design and editing easy. Even I can do some of them. Facebook allows us to target, but it is a warning, increasingly restrictive on things like vaping and switching. At a local level, experiment, keep post short. You will learn from your own insight in terms of what works. Boosting is really important. Facebook now, and unless you don't put a $5 or a $10 behind a post, it won't get any traction at all. You can see some of the responses we had from our Don't Wait campaign here. You find yourself engaging and responding, sometimes supporting people. You know, there's people talking about the impact on the advert, people tagging their friends and asking them to quit. We see that. People sharing stories about how smoking's impacted their own families. But again, kind of, you know, don't expect people to like you. And I think that's just something we've always got to take on the chin as well. You know, people will also stick 2 fingers at you, tell you where to go. And that's why I think, you know, having those interventions on television, it's just sometimes being effective is not always being likable. And I think that's something that we all need to recognise as well. On a budget, the Don't Wait campaigns, obviously, you know, it was recorded with good high production values, but it started out in life. Me standing outside the QE hospital in Gateshead, pointing an iPhone at Dr. Ruth Sharrock at the start of COVID and talking about smoking, and we boosted it. And over time, you look at that, 170,000 views. So yes, we have put some money behind it, but this is stuff that you can do yourself with an iPhone. Some of the things that we've done on social media, positive case and boosted positive case studies like Danny and Deborah. Bit of insight there is filming them in situ in their own environment. Deborah singing in her band, Danny in his hometown. That people seem to like that. Sue, some of you might know Sue Mountain, very hard-hitting health. Sue's told a story about how she had laryngeal cancer. You know, so talking about the finances, half a house instead of cancer. Someone we knocked up on Canva, how much could you save just using images, turning them into a video and putting a bit of money behind it, getting out in the streets of the Northeast, talking about smoke-free law. And then even just, you know, if there's new news about smoking, you know, so for instance, there's a story out today around the impact of secondhand smoke on families through the generations. Just taking a link from a credible news article and posting it and putting a bit of money behind it, you know, you're giving new information for smokers that they kind of need to know. So I'm going to round off here now, but I think the main point for me is coming back to this point around reinvigorating quitting and not thinking the job's not done. So our priorities, you know, as smoking prevalence falls, it's understanding who they are. And Ash have done a lot of great work in this area, you know, the social housing, mental health, pregnancy, and obviously, you know, Sonia's insight has covered a lot of that. It's understanding our audience, the pressures they're under, also understanding their experience and methods of quitting. So, for instance, we know a lot of smokers will cut down and use unaided quitting. So as Louise has highlighted, how do we move them close to ways that are going to work better? It's about giving them hope. It's about giving them tangible reasons why they can quit, why life will be better. And I think importantly as well, it's communicating new compelling facts. What are our new compelling facts that we haven't used yet? So, for instance, we know dementia, it's the third biggest risk factor for smoking. You know, we now know the risk factor for dying early from smoking is 2 in 3. Should we be communicating that, and how should we be doing it? We need to not ensure we don't demonise routes out of smoking, vaping in particular. We need to find ways talk about quitting for mental health more effectively, more important than ever, but people aren't believing it at this point. It's counterintuitive. And I think we need to reassure people that previous attempts aren't failures, but they're stepping stones towards success. And just quickly to round off, you know, campaigns, they're not like anything else in tobacco control, they're not a silver bullet, and there's no one silver bullet message works with everyone. But it's, in the words of the CON review, it's about comms helping create that climate for quitting. And that's me.
Thanks, Andy. That was really great, and thank you for speeding through those as well. If I could just ask Louise and Sonya to join us just for the last few minutes. And those are really interesting discussion in the chat. There's a really kind of vibrant conversation around healthcare professionals. So we have a session on healthcare professionals coming up. So we might park some of that stuff for when that's coming up. I'll look up the date before we finish. But I just wanted to come back to this sort of hard-hitting messages. There's a bit of conversation about that in the chat, and obviously you were picking that up as well, Andy, in your presentation, and around the discomfort that smokers and also healthcare professionals might feel around those hard-hitting messages. I just come to Sonya as well for your reflections, but to Andy and Louise first. You know, what would you say around the importance of having those hard-hitting messages and how we land those in a way that is going to engage smokers and not turn them off?
I think it's really important not to put out any message that stigmatizes smokers.
Yeah.
In fact, even the word smoker, you know, when people are defined as smokers, a lot of people absolutely hate that. So I know there's a lot of push to talk about people who smoke, you know, the people first language, which I think is really important. And I think whatever communications you put out, you know, talk to some people about how this feels, how this sits with them, and use those insights, but also make sure that you keep them with you and look at the positives of quitting, not the pain, the hardship, and yeah, sort of like put yourself in their shoes.
And Andy, you were saying, you know, you can't expect to be liked, you can't expect necessarily when you're giving these difficult messages for that to be something that people feel okay about. How could you expand on that?
I think, yeah, I think first of all, you know, the global evidence base is really strong, and this has been studied in many countries around the world. I mean, the Dixon former smokers from America, where they've got those hard-hitting case studies, smokers talking about, you know, what it's like in their own lives. I think that's really important, and you know, they've evaluated really well around the world. I think there's two things going on here as well. I think there's raising motivation to quit as a tactic in itself, and bringing people into support, which I think are sort of slightly different and require those slightly different messages. But we've certainly seen that some of the best performing campaigns that we've run actually have been those that have been quite graphic, but still sympathetic and empathetic, you know, replaying people's lives. There's nobody who hasn't lost anybody to smoking. So you know, I think the kickback for those campaigns, you get them equally with just a positive quit smoking message and a negative one as well. So I think everything has its place, but that's still really important. And we know from some of the national research that, you know, that some of those awareness and exposure to quit smoking campaigns have fallen, and the reasons to fall. Now, people will always find reasons in their own lives, and then you know, health always underpins that. But it's personal cues, and I'll probably let Sonya come in here. But
go on, Sonya. You add your thoughts from the insights work around those sort of uncomfortable messages.
Yeah, I think that, you know, it's something that we've discussed with Fresh, and it's a constant debate, isn't it? And I think that what we've seen recently is this move towards the balance between harm and hope. And so whilst I think these health messages are still very important, and certainly I think you have to keep with those, because the young people taking up smoking need to hear those and need to be, you know, aware of the health harms. There is a real sort of a want amongst smokers to be supported and encouraged and aspirational. So it's not about, you know, oh, bad person for smoke. Well, actually, we all know it's not about bad person for smoking, but it's not all about, you know, these terrible things are going to happen to you, but more about as well. And these wonderful things can happen to you, you know, if you stop smoking, you know, whether they're financial, whether it's about, you know, being free of the sort of the ties. You know, people talk about being a slave to nicotine, or being, you know, just dominated by it, and that sort of freedom. So there's a lot of call amongst smokers to, you know, especially older smokers, they know the badness, they know the health harms, and they really respond to that nurturing and encouragement and aspiration side of things. So I think finding the balance, I mean, you know, in terms of communication of you know, the health harms, it's a tricky one. And, you know, we've talked to people in maternity and midwives about how difficult that is to retain a really good relationship with the woman who you're meant to support have a baby, but at the same time be giving these hard messages. It's a really tricky tightrope, I think.
I was just going to say, as well, as we've tried different methods in focus groups to kind of to test campaigns, and what is quite interesting sometimes is when you run a confidential scoring system where you get people to talk about a message, or they see a particular type of ad, that the responses confidentially are often quite different to what will happen, say, in a focus group or a focus group. People are more likely to say, you know, I know the risks, you know, this again and stuff, but confidentially that can be quite different when you ask people to score and comment. So, you know, some of those campaigns sometimes, you know, how they might land in a group where you're more likely to see that denial and a bit of the kind of, you know, the brushing it all off and stuff is sometimes quite different to say how it might land and sort of, you know, taken personally.
One of the things I take, go on, Sonya.
Also, one of the things I remember quite vividly was, I think it was the 16 cancers campaign. That, you know, you go and if I had a pound for every smoker I've sat in a focus group with and said, you know, well, something's going to kill you, you might get hit by a bus tomorrow, you know, that sort of thing. And it's about that jump to death, if you like, whereas actually the messages that came from that campaign about being seriously affected but still living. So the images were of the lady sitting at dinner with her family and pouring, you know, her mushed up food in, you know, she couldn't eat because she'd had throat cancer or whatever it was. So I think some of that thinking about living with severe disabilities caused by smoking are possibly more impactful than you know, it's going to kill you.
Yeah, I think that's really interesting, Sonya. I'm just going to pause there because we are basically at the end of the webinar. And I think one of the things I take from the conversation that we've just had, and I think something that we'll maybe come back to, is that the insights are the starting point, but we need to, you know, you need to interpret what we're getting back, think about how we're applying them into our communications approaches, into the way that we're trying to attract people into services. And I think it's been, there can see there's loads and loads of vibrant stuff going on in the chat that we've not necessarily had a chance to cover, and also people posting their own sort of the ways that they're seeking to engage smokers and communicate with smokers. We'll capture all of that, and if people have got stuff that they've not shared, please do share it with us, because I think it would be great to have a look at the current stuff that people are using and doing, and how we're kind of playing that back to our smokers, and it would be good to kind of share this as a community. So thank you so much to Louise and Andy and to Sonya. Sonya will be back on your screens on Tuesday at 10 o'clock, and we'll go into much more detail about some sort of specifically disadvantaged populations. And then on Tuesday the 4th, we're going to spend some time concentrating on pregnant smokers. We've had a few people commenting about pregnancy in the chat, so definitely come back for that one. And then on the 18th of October at 10 o'clock, we have the one looking at healthcare professionals and their perceptions and attitudes, which again, I think will be really rich and interesting, particularly some of the conversation that we've had in the chat today. So look forward to seeing you all back there on Tuesday, and thank you to all the speakers, and do enjoy the rest of your day.
Thank you, Hazel.
Thank you, Hazel.